A British chemist said, I wonder how it is in orange juice. And guess what? It's just fine. For 3 months, it's stable. So the cheap way to do it is you crush 5 50-milligram tablets. Kids' juice boxes are 4 ounce. 2 kids' juice boxes, which is shelf stable. The reason you want shelf-stable orange juice is regular orange juice is not going to last 3 months in the fridge, right? But the shelf-stable stuff is typically good for 3 months. You crush it up, keep it in the fridge, stir it up each morning, morning doses so you don't get sleep disturbance. I give them a 1 cc syringe if I'm treating an acantholytic disorder, or it's a teaspoon if you're treating an inflammatory disorder. Makes it super inexpensive, easy for the patient to do. N-acetylcysteine. How many of you guys are prescribing NAC for things? Lots of people, right? It is TNF, so you get an anti-inflammatory effect. Pentoxifylline is TNF. When I have patients who you're trying to bust granulomas, and you're just not getting where you need to be with other things, including JAKs, you add NAC and pentoxifylline, you're just adding to that TNF effect, and it's a really low cost, low morbidity way of adding TNF effect. It's also great for compulsive disorders, trichotillomania, nail biting, acne excoriae. It works for all of those. 600 milligrams 3 times a day. You can double that dose if you need to. And for delusional parasitosis patients who just don't want to take any psych-type drug, they'll take this. And it often gets them to the point where then they'll accept the aripiprazole and the other drugs. My favorites for delusional parasitosis, remember all those bug articles I used to write? Every patient with delusional parasitosis in the entire globe tracks me down because I'm the only one who will understand, right? I've gotten really good at delusional parasitosis. First thing is, don't confront them, don't fight with them. I can see you're really suffering, right? Would you do anything to get better? Yeah, do anything to get better. Well, give this medicine a try. And I tell them, doxepin is a drug we use all the time in derm. It's a tricyclic antidepressant. No one uses it as an antidepressant because it's a lousy antidepressant, but it's a great antihistamine, right? So we have all these drugs that we use for other purposes. So if you read about this drug, you'll see that this too is a psych drug, but it works for what you have, and it works really, really well, right? Remember, your target dose for all of them is 10 milligram. Don't even bother lower doses, except for risperidone, where it's 4 milligram. So, pretty much any of the others, olanzapine, aripiprazole, pimozide, they're 10 milligram, and you just start there. Lower doses are just not going to work in my experience. And because of those bug articles, I've had a lot of experience with this, right? You just start out at 10. And it's not that they suddenly gain insight. They just stop talking about it and get better and get on with their lives, right? And most of them eventually stop the med over a few months, and they don't have recurrence of their symptoms. About 30% recur, and their family usually brings them in. They got so much better. All their skin lesions healed when they were on that med. Can we get them on that med again, right? Risperidone, you get weight gain. Olanzapine, you get extrapyramidal effects. Aripiprazole's got almost no baggage. You start at 10, don't be afraid to go up to 40. It doesn't have a lot of drug interactions. You don't get the lactation that you can get with risperidone. So aripiprazole 10. If you're going to write one thing down from this lecture, aripiprazole 10, which is, I'll use the brand name so you recognize it, Abilify, right? I'm in the South. Patients are fun in the South. They're polite. Even my delusional patients are kind of fun in the South. Had one patient who, her life was just out of control with it. On aripiprazole, on Abilify, she was so happy. She brought us in a big Abilla pie that she had baked for us. Okay. Severe pruritus. This is a high-functioning, high-strung PhD. She has seen 20 dermatologists. If any of them had been remotely competent, she would not be in this situation, right? So first off, what does she have besides anger and personality issues, right? She's got steroid atrophy. Patients with steroid atrophy itch. And they burn and they itch and they're angry. Always think anyone who's not responding and has seen other people